Hello everyone, my name is David Cunningham and I'll be talking to you today about the OPRA Implant system, or the Osseointegrated Prostheses for the Rehabilitation of Amputees. Now, just to get us off started with an introduction to the topic, although statistics for costs could not be found for Canada, in the United States, costs associated with lower limb amputations exceeds around $4 billion annually. In Canada, between 2006 and 2011, a total of over 44,000 lower limb amputations were performed, 23.9% of which were transfemoral amputations. This means that over the course of 5 years, there were over 10,000 new Canadian transfemoral amputees relying on the Canadian healthcare system for rehabilitation and post-surgical treatment. There are a number of different options for lower limb amputation, but in most cases of LLA, a care team will attempt to salvage as much healthy tissue as is possible. This helps to retain the greatest number of functional joints as possible in a patient. The effort can result in allowing larger natural torque generation to remain and lessen the overall energy expenditure required for ambulation. However, when a distal amputation is contraindicated due to existing pathology or if perfusion of local tissue is of concern, a more proximal amputation may occur. Now, if a surgeon overshoots the cut point, reamputation may have to occur at a more proximal location. This is usually due to insufficient perfusion of the stump, leading to complications in wound healing. I've blurred an image here as it was pretty graphic, but as shown you can see that there has evidently been a severe complication in the healing of this patient's transmetatarsal amputation. There are a number of different medical conditions that may prompt amputation of the lower limb. However, the most prevalent causes include complications associated with diabetes and other vascular diseases, trauma, congenital limb deformations, or even bone cancer. Now, transfemoral amputations are amputations that occur between the knee joint and the hip joint and are one of the least desirable levels of lower limb amputation and are reserved for circumstances when there is inadequate tissue closure of a more distal amputation, there's not enough tibial length for a below knee amputation, or when a through knee or below knee amputation will not resolve the underlying pathologies indicating the need for amputation in the first place. The transfemoral amputation is less desirable as the location of the amputation severely limits the biomechanical advantage required for ambulation, thereby dramatically increasing the energy expenditure required for ongoing mobility. Now that we've clarified what pathology is being combated, we'll move on to the societal needs stimulating development of medical products for transfemoral amputees, the quality of life implications of different solutions, and the available assistive devices that transfemoral amputees can choose from, and the associated medical technologies enabling use of osseointegrated transfemoral prosthetics. After transfemoral amputations, many patients are bedridden or lack the ability to regain independence. With mobility aids, transfemoral amputees have a chance of regaining their mobility, independence, and cardiovascular health. This is through the design of mobility aids that facilitate independent mobility in a pain-free manner without excessive nuisance to the patient. Overall, this means designing an implant that will help patients regain their pre-amputation quality of life. We've discussed regaining quality of life, but what does that actually mean to a prosthetic user? There are many ways of interpreting quality of life, but femoral mobility solutions are evaluated using a QTFA score, or rather the questionnaire for persons with a transfemoral amputation. This 70-question evaluatory measure is self-reported and investigates 4 main categories. The device use score evaluates the amount that the quality of life solution is used per week. This is measured in the number of days per week multiplied by the hours of a day, where the perfect score of 100 indicates that the prosthetic solution is used for every day for over 15 hours. The device mobility score is defined as the ability or performance of the amputee to change or maintain different postures. This covers a wide range of 19 items, ranging from how much additional aids are used to the habits and duration of the solution use. The problem score evaluates the number of problems and severity of problems that are experienced with the device, and the global score is the general score where the user is asked to rate their overall perception of the device, whether or not the amputee perceives that the device is impacting their life in a positive way. This evaluation measure is good for ranking different solutions against one another, but in reality the answer is much more straightforward. Quality of life to an amputee is the same as any other general definition. It is the standard of health, comfort, and happiness experienced by the individual, and more specifically, how well the transfemoral amputee perceives the change in their happiness before and after their amputation. The goal of any assistive device is therefore the same: to maintain or increase perception of happiness, whether that be through aesthetics, mobility, or most generally, reduction of perceived limitations. Although loss of any limb results in major personal and societal implications, the loss of a lower extremity can have especially profound effects on the independence, mobility, and quality of life of the patient. The OPRA system is one of very few transcutaneous orthopedic prosthetics, so instead we will focus on other potential solutions to the quality of life problems associated with amputations of the lower limb, specifically transfemoral amputations. There are three major mobility device classifications available to transfemoral amputees. These include wheeled mobility aids, socket prostheses, and the more novel osseointegrated prostheses. Interestingly enough, wheeled mobility aids, although classified as FDA Class 1 devices, are highly regulated through both ISO and ANSI standards. The design of wheeled mobility aids is also open to third-party review from the Accredited Persons Program. In contrast, femoral socket prostheses are highly unregulated, are 510K and GMP exempt, and do not have third-party reviewing processes. Osseointegrated femoral prostheses, on the other hand, are FDA Class 3 devices, but there is little to no formally enforced standardization in testing procedures or design criteria when seeking approval for these transcutaneous prosthetics. This is likely due to the novel nature of the implants, but as Class 3 devices, osseointegrated prosthetics are highly scrutinized by regulatory bodies before they can be tested and used in patient care settings. Most evaluation of novel osseointegrated prosthetics is study-specific and will be discussed later in this presentation. Over 3.6 million Americans are using some sort of wheeled mobility aid to increase quality of life and independence. Wheeled mobility aids are readily available and cost-efficient, and they are usually covered by medical insurance. Additionally, they require little to no post-incident rehabilitation or training to use effectively. However, wheeled mobility aids suffer from a lack of versatility, a lack of infrastructure-independent mobility when compared to prosthetic options. Most importantly, wheeled mobility aids are frequently perceived as limiting to a patient's quality of life, as there is a substantial reduction in overall mobility. Socket prostheses are suspension mechanisms for prosthetics and are versatile and adaptable to many different environments. Additionally, socket prostheses provide the ability for a patient to regain some aesthetic semblance of a natural leg and foot, allowing patients to wear normal clothing and shoes. However, socket prostheses are not perfect. Limitations of socket prosthetic options include development of chronic skin conditions, formation of pressure ulcers, persistent pain, change in volume of the stump, soft tissue scarring, extensive area of skin grafting required, restricted mobility, and socket retention issues arising from excessive perspiration. Predominantly in response to the severe downsides of socket prostheses, direct attachment prosthetics were developed. Direct attachment or osseointegrated prosthetics are prostheses that permit direct attachment to the distal skeleton in femoral amputees, avoiding the inherent problems of the socket suspended prosthetic while still experiencing all of the pros of the socket prostheses. Osseointegrated prosthetics also exhibit increased range of motion when compared to socket prostheses, and even permit osseoperceptive feedback, where the user is capable of feeling feedback from the walking surfaces encountered. Unfortunately, osseointegrated prosthetics are extremely invasive and present high risk of infection, both deep and superficial. Additionally, as they are anchored directly to bone, osseointegrated prostheses are more prone to mechanical failure than socket prosthetics and also present a risk of fracture if the patient is overloaded. Now that we have outlined the general logic behind the development of the OPRA implant system, we will move on to discuss scientific and engineering principles contributing to its development, as well as the state-of-the-art competitor products and their relative efficacy in comparison to the OPRA implant system. As mentioned before, osseointegrated prostheses are prostheses that permit direct attachment to the discal skeleton. As you can see in this image, this osseointegrated prosthetic is inserted into the upper femur and is ultimately accepted into the bony tissue and encapsulated to provide strong fixation of the implant. This process is known as osseointegration and can either be stimulated through use of bioactive surface materials or facilitated through the use of porous surface profiles to allow for bony ingrowth to occur into the voids of the metal. In this diagram, the bone is at the bottom and the porous metal is at the top. At 6 months post-surgery, you can see that the bone is actually ingressed directly into the porous metal, effectively anchoring the metal to the bone. So just to provide a brief history on osseointegration, osseointegration was first introduced in the 1950s as a conceptual theory that bone could fuse to a metallic implant. This was followed by a few experimental studies, but it was not until 1965 until osseointegrated prosthetics were designed for human use in the context of dentistry. Currently, it's a common practice to incorporate osseointegration into orthopedics implant designs. However, transcutaneous implants are much less common, and with the exception of dental implants and catheters, the FDA hasn't approved really any transcutaneous prosthetics, especially in the context of orthopedics. We've now mentioned the term transcutaneous a number of times, but it's important to know what that is. Trans meaning through, and cutaneous referencing the skin, results in the compound word transcutaneous, meaning any device that is designed to penetrate through the skin. There are many examples of transcutaneous devices, but catheters and ports are likely the most well known. Transcutaneous femoral prosthetic implants were originally developed in 1997 in Sweden, and although a number of design options are available, only one, the OPRA device, have been given pre-market approval by the FDA. There are a few design considerations that must be taken into account when designing a transfemoral implant. Durable fixation to bone is absolutely necessary, as the bone implant interface will be under constant cyclical loading during the natural gait cycle. This means that sufficient load sharing must occur between the implant and bone, but load transfer must occur efficiently, as too much load relief from the implant may result in stress shielding. Biocompatibility is also essential during design of the prosthetic, ensuring that, due to the implant being in direct contact with the hemopoietic or blood-producing tissue, no oxidation of the metal will occur. To begin our discussion on design considerations, we will start with one of the most important, biocompatibility. The OPRA implant system is manufactured from titanium materials which are readily accessible in the orthopedic implant industry. These titanium materials eventually lead to fibrous encapsulation, so cathodic behavior is not of concern. The next design considerations are associated with the mechanical behavior of the implants, using testing procedures aligned with ASTM standardization. Torsion testing, involving fatigue-oriented cyclical tests of up to 10 million cycles, are used to validate the fatigue behavior of the implant, as well as bending testing to evaluate the maximum allowable single-point eccentric forces to be encountered by the OPRA implant system, are performed on all components. Wear testing is also performed on components with variable interfaces, such as the abutment fixture and screw, to ensure that everyday usage will not result in abrasive failure. Other concerns such as sterilization and shelf life are also indicated for the OPRA system, where gamma sterilization procedures occur during manufacturing of all components, and the uninstalled implant has a shelf life of 5 years after sterilization, as sterilization procedures can result in accelerated wear or oxidation, leading to variance in the specified geometry. The OPRA implant system is a state-of-the-art osseointegrated implant system and is the only transcutaneous femoral implant that has received pre-market approval from the FDA. In comparison to other transfemoral implant systems, the OPRA implant system uses a novel helically screwed, bioactive, and porous fixation device, whereas previous transcutaneous implants have used press-fit titanium stems with a grit-blasted surface. Comparing press-fit osseointegrated implants with the OPRA helically screwed method, data has shown that press-fit osseointegrated implants have slightly better survival rates and shorter time to weight bearing. However, several studies have reflected that helically screwed fixation methods can lead to increased long-term function, activity, and quality of life. Currently, there are only 3 transfemoral prosthetic options available. These include the endo-exo femur prosthesis from Steinbach and Grundy in Germany, the Osteointegration Group of Australia, Osseointegration Prosthetic Limb from the Osseointegration Group of Australia, and the integrated leg prostheses from OTN Implants in the Netherlands. All the competitor models use press-fit transcutaneous stems for fixation instead of the biohelix method as used by the OPRA system. In addition to the materials engineering advances that enabled the OPRA system to osseointegrate so well, there are a number of implantation considerations before the implant can be installed transcutaneously. The OPRA implant system is installed in 2 stages. The first stage, where the biohelix stem is installed directly into the bone, and a bone graft is used to plug the implant in place. This allows for bony ingrowth to occur into the implant, affixing it in place without loading. After the first installation is complete, the surgical skin flap is closed and the patient allows for healing to take place over 6 months before having the second procedure. In the second stage, the site is reopened and components are removed before a fixture abutment and an abutment screw are installed for connection to the external prosthetic leg and knee options available. In summary, after the initial installation is completed, the implant fuses to the bone with that osseointegration that was discussed before. When the abutment is installed, poking out of the skin and allowing the prosthetic to be attached. The prosthetic attachment can then be used for a variety of different actuated as well as non-actuated prosthetic devices adapted to the user's needs. In the context of engineering design considerations, in order to combat the 2 main inherent failures of the OPRA implant system, Integrum.se, the designer and manufacturer of the OPRA system, has adapted surgical technique, developed antibacterial coatings, and optimized the sterile manufacturing practices of the OPRA system. In response to the fracture risk associated with the OPRA, a roto-safe device, the OPRA Axor system, is developed to provide bending moment thresholds, releasing the prosthetic attachments when overload occurs, thereby protecting both the implant and the patient from experiencing excessive stresses leading to failure of the implant or fracture of the native bone. The OPRA implant is intended to increase quality of life in patients who have transfemoral amputations due to trauma or cancer, who have had rehabilitations with, or cannot use a conventional femoral socket prosthesis due to recurrent skin infections or ulcerations, unmanageable pain, or an amputation stump too short for use of a conventional socket prosthesis. Volume fluctuations, soft tissue scarring, or extensive area of skin grafting, socket retention problems, or restricted mobility are also indications for the OPRA system. However, the OPRA system is not intended for patients with incomplete skeletal growth, osteoporosis, high body weight, concurrent diseases, or pregnancy, amongst other contraindications. The OPRA implant system was approved by the FDA for pre-market approval on December 18, 2020, after 2 years of amendments and after 5 years of FDA approval under a humanitarian device exemption, with 6 years of previous amendments. An ongoing FDA pre-market approval study is currently active through clinicaltrials.gov, evaluating the efficacy of the OPRA device. Prior to FDA pre-market approval, 3 separate studies were published on the same patient population as in the OPRA implant study. These include a clinical trial using radiostereometric analysis to evaluate stability, a gait analysis study using kinematic data to evaluate changes in gait pre-op and post-op of the OPRA system, and a quality of life study using a standardized questionnaire to evaluate the changes in quality of life in patients with the OPRA implant system. The clinical data reported in the aforementioned studies indicates that the OPRA implant system results in favorable levels of patient satisfaction when compared to classic socket-based femoral prostheses. Additionally, the associated complications are deemed to be at acceptable risk. Overall, studies have shown fewer problems and better overall quality of life in the OPRA implant system users, with better mobility and increased prosthetic use commonly reported as positive outcomes of the OPRA system usage. There maintains a definite risk of infection and mechanical failure. However, clinical evidence suggests that infection and mechanical failures are manageable. In summary, the reported clinical evidence supports usage of the OPRA implant system. The largest future iteration of the OPRA system is the e-OPRA system, which uses EMG sensors implanted into the thigh to read voltage changes in the quadriceps and hamstring muscles. This actuated prosthetic will enable use of a powered knee, further reducing the energy required for movement while using the transfemoral prosthetic. This particular design of implant is particularly unique, as the combination of implanted EMG paired with nerve medialization results in phantom limb proprioception, where the implant can actually be recognized and perceived by the brain using the AMI, or agonist-antagonist myoneural interface. This also results in the ability for the user to control the knee and ankle power joints discreetly, instead of relying on a motion couple or exterior sensor arrangement for pseudo-control of the actuated prosthetic.